Hey everyone, and welcome. Today we are digging into a real puzzle for the modern microlab. We're talking about an emerging pathogen that really puts our diagnostic skills and our trust in automated systems to the test. All right, let's just jump right in with a question that honestly should make every single one of us in the lab stop and think. You get an isolate, you pop it on your automated system, and out comes an ID. Simple enough, right? But what if that ID is just plain wrong? And what if that one mistake could have huge consequences for the patient? Well, that's the exact situation we're going to break down today. We are pulling the mask off an imposter called Psychrobacter phenylpyruvicus. This thing is a master of disguise, you know? Our go-to systems often get it mixed up with common bugs like Acinetobacter or even Neisseria. And as you're about to see, getting this one wrong is a really big deal clinically. So, before we really get into the nitty-gritty, I just want to be super clear about where all this info is coming from. Everything we're talking about is based on a really deep dive into the literature, and we used a Gemini deep search to pull it all together. And for all of you who want to check the original papers, the full list of sources is right there in the notebook document linked for you. Okay, let's do this. Section 1. We're heading to the bench to get our hands dirty and figure out how we can start to unmask this tricky little organism.
First stop, the gram stain. It's obviously our critical first step, but wow, it can also be a huge pitfall here. Psychrobacter phenylpyruvicus is a gram-negative coccobacillus, but, and this is a big but, it often hangs onto that crystal violet and resists decolorization. So what happens? It can look gram-variable or even straight-up gram-positive, and just like that, you're headed down the completely wrong path. Now, on the plates, it's a strict aerobe. It'll grow on your blood and McConkey agars, and it's a non-lactose fermenter. And, true to its name, psychro means cold. This guy can actually grow at 4 degrees Celsius. Kinda neat.
Think of this table as your bench-side cheat sheet. A few really simple biochemicals can give you some powerful clues. So, first up, look at the oxidase result. It's positive. Boom! Right away, that helps you rule out the oxidase-negative guys like the Acinetobacter complex. Then, you add in that it's non-motile and urease-positive. Okay, good to know. But honestly, the real kicker here is colistin. It's susceptible. That's huge because it really sets it apart from so many of those nasty, intrinsically resistant non-fermenters we deal with.
And this right here brings us right back to that core problem we started with. Your bench work is giving you all these clues, right? But the automated systems, which are totally reliant on these same phenotypic traits, are just, well, they're notoriously unreliable for this bug. They're just trying to find the best fit in their database. And for Psychrobacter phenylpyruvicus, that best fit is usually the wrong one.
So, here's the bottom line. When your bench work and your fancy automated system are just leaving you scratching your head, you've got to go molecular. Period. 16S rRNA gene sequencing is the gold standard right now. It's how you get a definitive, dead-on accurate ID for Psychrobacter phenylpyruvicus and just slice right through all that phenotypic confusion.
Okay, so let's get practical. What do you actually do when you think you have one of these on your bench? This algorithm is basically your safety net. Step 1, put out a descriptive prelim, something like oxidase-positive gram-negative coccobacilli. Whatever you do, don't commit to a wrong ID. Step 2, get on the phone. Proactively call the clinical team, let them know about the diagnostic uncertainty. And step 3, pack it up and send it out to a reference lab that can do the definitive 16S sequencing.
All right, let's shift gears into section 2. We've just spent a lot of time on the how of identifying this thing. Now let's talk about the why. Why is it so incredibly important to get this right for the patient?
This number, it really says it all. 44.4%. That's the reported overall mortality rate for infections caused by the entire Psychrobacter genus. Just let that sink in for a second. This is not some lab curiosity we're chasing. We're talking about serious, life-threatening infections where the stakes are as high as they get.
And this table really breaks down where this bug causes the most damage. I mean, it is a classic opportunist, right? It goes after our most vulnerable patients. You see bacteremia and folks with liver cirrhosis or HIV. You see absolutely devastating meningitis and VP shunt infections, especially in preemies with neurosurgical hardware. The common thread running through all of these, a severely compromised host.
But then, just when you think you've got this bug figured out, the literature throws you a curveball. There's this case of an 8-year-old boy described as previously healthy who comes down with both bacteremia and pneumonia. This case is such a critical reminder for us. Yeah, it's rare, but we can't get too comfortable with their definitions. This bug can cause serious disease, even in people who don't fit that classic immunocompromised picture.
Okay, on to section 3. So you've done it. You've correctly identified Psychrobacter phenylpyruvicus. The ID team calls you up for guidance on treatment, and this is where things get really tricky.
The huge challenge here is that there are absolutely no official standardized treatment guidelines. None. So what you're looking at here isn't gospel truth. It's a starting point, right? It's been extrapolated by experts based on published case reports and by applying principles from solid guidelines like the Dutch SWAB guidelines. So for bacteremia, maybe you'd consider ceftriaxone. For something really serious like a CNS infection, you'd need an agent with great penetration, like meropenem. And when it comes to kids, it's an even bigger challenge. Every single dose has to be meticulously calculated based on weight. The handful of case reports out there suggest that things like ampicillin or ceftazimab have worked, but getting that dosing exactly right is everything. It's the key to both efficacy and safety.
This quote just nails the clinician's dilemma, doesn't it? But it also throws the problem right back into our court in the microbiology lab. I mean, think about it. If there are no official treatment guidelines, how on earth can there be official susceptibility breakpoints? How are we supposed to interpret the MIC values we're generating at the bench?
Okay, listen up, because this slide is probably the most practical, hands-on takeaway from this entire explainer. This is how you deal with the no breakpoints problem. UCAST actually has a formal framework for exactly these situations. It's all about using breakpoints from what they call surrogate organisms. So for Psychrobacter phenylpyruvicus, we look at its relatives. For something like meropenem, you'd use the Acinetobacter breakpoints. For an agent like ceftazidime, you'd pull the breakpoints for Pseudomonas aeruginosa. This isn't just a guess, it's a rational, defensible strategy that lets you give the clinical team a meaningful interpretation.
All right, we're in the home stretch, our final section. Let's quickly talk about infection control in the hospital, and then what the path forward looks like for understanding this bug.
So, there's some good news here on the infection control front. You don't need to do anything crazy. The foundation is just good old standard precautions with a real emphasis on meticulous hand hygiene. You'd only add contact precautions if you have a patient with, say, a big draining wound that's not contained. And thankfully, it's easily killed by our standard hospital-grade disinfectants, so no special protocols needed. And that really brings us full circle, back to the big, critical question this whole explainer is about. When you think about all the pitfalls with the gram stain, the unreliable automated IDs, the complexities of AST, ask yourself honestly, is your lab prepared to correctly identify this emerging pathogen?
You know, our understanding of these rare bugs like Psychrobacter phenylpyruvicus, it's built by us, the community. It's built one case report at a time, one shared experience at a time. So if you found this useful, please subscribe to the channel. But even more important, share what you've seen. Tell us about your lab's experiences with this organism down in the comments.
And just one last time, if you want to dive into the original research, the complete list of all the primary sources is in that accompanying notebook document. Thank you so much for watching.